Hi there, this is my intradermal OSCE for intradermal lignocaine. This is indicated in patients who require IV cannulation and to avoid or minimise the amount of pain experienced by a patient when inserting an IV cannula. We will give them an IV intradermal lignocaine block. Okay, so going over a couple of pieces of equipment that we must have. Okay, donning PPE, which is gloves, safety glasses, and boots. Obviously the first and most important thing is to gain consent with the patient, first of all allowing us to get an understanding of what they understand the procedure to be, and also completing any misinformation and tidying it up to allow them to have the best possible understanding of the process and procedure itself. Okay, I've got my drawing up needle. In this case here I'll be using a 22 gauge needle, however this is going to be my drawing up needle, however in reality I would be using a red blunt end drawing up needle. I've got my 25 gauge needle, precision glide, which is what we're going to be using to administer it. Preferably want to use a 3mm syringe, however I've only got a 1mm syringe, but we will only be drawing up 1mm of lignocaine and 1mg. I've also got my gauze plaster there as well to minimise any potential bleeding or anything like that. Okay, so first and foremost what we have to do is we're going to drug check our lignocaine. Okay, this has been pre-checked by my offsider. I'm going to now check this. So xylocaine 1%, lignocaine injection 50mg in 5 mils, May 17. So it's in date and this has been checked by my offsider. Okay, what we're then going to do is explain and gain informed consent with the patient. Okay, once the patient has partaken, has given me their consent, what we're going to do is we're then going to check if they've got any allergies or any severe allergies to lignocaine. The patient has no known allergies to lignocaine, so this allows us to continue. With my alcohol swab, what we're going to do is open our alcohol swab and we're going to do the aseptic technique, and basically starting in small circles, working outwards, and it's just going to kill any germs and that's going to be disposed of. Then what I'm going to do is grab my 1mm needle, remaining as aseptic as possible. Going to open up my drawing needle, going to attach it and opening it. Okay. Then what I'm going to do is I'm going to open up my pre-drug checked lignocaine. Okay, and what we're going to need to do is just making sure that we stay to sharps etiquette. So what we're going to do is I'm going to inform everybody when the sharps are out. Sharps are out, and I'm going to draw up 1mg and 1ml of lignocaine. Just going to dispose of any excess and bubbles. Cool. So that there is my 1mg and 1ml of lignocaine for an adult. Okay. This can go up to 1.5, however I will be giving 1. Okay, and with the lowest dose being 0.5. Okay, then what I'm going to do is I'm going to detach and discard of the sharps into the sharps container, which I have to my left. Okay, I'm then going to open up the administration needle. Okay, and I'm going to explain to the patient that due to lignocaine's properties, they will experience a slight sensation of stinging. Okay, however this is common and to be expected. We can also monitor the patient for any sort of changes in their levels, or their vitals, sorry. So what we're then going to do is we're going to take the tip off, sharps out. And what we want to do is spread the skin. I'm going to go on a 15-degree angle. Just scraping the top. Okay. We're then going to aspirate to make sure we're not in a blood vessel. And once I'm happy, I'm going to introduce the lignocaine to the site. As we can see, we've got a white pustule forming, and this is what we're looking for. Okay. Once this has been administered, I'm going to dispose of my needle in the sharps container. Okay, that's been disposed of. Okay, if there's any bleeding or anything like that, we can pop this over the top and I can release my Z-track. What we're looking for is a white pustule, and what this means is that the lignocaine is located in one primary site, and then we can go in and IV cannulate over the top of that. Okay, it will be sitting directly over the vein, and we just need to make sure that we're going only into the dermal layer of the skin, remaining nice and shallow as we enter in. Okay, I'm then going to document on the PRF or EPRF the time that it was done, the amount that was given, the gauge of the needle and the location. Okay, and I'm going to monitor the patient's vitals and see if there's any adverse reactions.